And it was a perfect talk to now talk about this epidemic of heart failure and what we can really do as we talk about trying to design heart failure clinics. China has done a great job, as you have designed what we call in the U.S. a hub and spoke model for our patients. So what I'm going to try to cover in the next couple of minutes is how we can actually lead our heart teams, how we can make sure that we utilize a team-based approach in order to take care of our patients, and what that really means. Because at conferences such as this, we learn all of the great background, the clinical guidelines that we need, but now we need to take it out into practice to make sure that we get to our patients and how we're going to build that dream team. So first we're going to start with how we actually have to lead our CV teams, because most physicians are not trained in leadership. They're very well trained in clinical expertise, but we're going to talk about these things then in the U.S. we call non-clinical competencies. Oftentimes they're called soft skills. And what are we talking about? We're talking about this epidemic that we have of our patients, the number of patients that have heart failure, and how we can ensure their compliance with our treatment plans, making sure that we follow guideline-directed medical therapy. So these are the key elements that we feel are necessary to be a leader in our healthcare systems. We'll talk about emotional intelligence in a second, because that's probably one that's a little bit more difficult. But we also have to be ready for change readiness. We have to understand our environment. We have to understand how our patients can get to us. We have to be able to build communication, because if we explain things to patients in our clinical language, they will not understand us. So we need to make sure that we have explained to them exactly what their disease process is and how to live with it. And then good leaders on the right-hand side of the slide, how you connect individuals, how you think strategically, how you actually have some business acumen, because we've talked throughout several sessions in the conference how important advocacy is as we talk about taking care of our patients. And then to be a true leader, I'm just going to put this in for a second, we have to be humble. We've got to make sure that we're always truthful with our people that we're trying to lead, and we have to be trustworthy, because without that, people won't trust us. So what is a good leader of our heart failure teams? Number one is they have to influence. The dynamics between individuals is not often easy. So being able to understand where people are coming from, the better your leadership ability will actually be. This thing called emotional intelligence, what do I mean by that? I mean how people see you. Oftentimes, we'll often see ourselves in a very different manner than how other people see us. It's very important for our teams that they can understand who we are and what makes us tick. The issue with physician leaders is, for the most part, in the United States and as I travel globally, you graduate and you become a physician, and you have gone through an enormous amount of training, and so the administrator of the hospital says, I want you to run my heart failure clinic, or I want you to run my cath lab, I want you to run my non-invasive, and you have no idea what they're talking about, because we don't train our physicians to be these leaders. So I think it's important that we add these different elements so that when you become a leader of an area that you actually know what that means, because they're very complementary to each other, and you need to understand your environment. So what is leadership? Number one, it's setting direction. We just heard about the incredible epidemic of heart failure everywhere across the globe. But what direction? What do we want to do that's actually going to solve this? So you have to have a purpose. I call it our true north. Where are we going? We have to influence others, because in order to change how we deliver care, the pandemic taught us one thing globally, and that is we must transform how we deliver heart care. And then we have resource utilization. No matter where we are in the world, we have a limited number of resources. We had the privilege of seeing one of your hospitals yesterday that don't have enough nurses. They can't open their beds because they don't have enough nurses. We also had Peking University Third Hospital that we gave an award to because they started a cardiometabolic clinic. So that was where their true north really was. Because leadership is not a position, it's not a title. It's not being a professor or a director. It's about leading and having action. And it's a lot of different social influences that get us there. So what's needed? Number one is we have to learn how to adapt to our environment. We also have to learn this emotional intelligence that we've been talking about. And then we have to build a different skill sets, very different than diagnosing patients. We have to make sure that we can communicate really well with our team. Who are leaders? Anyone with a vision can be a leader. I used to think that we could not teach leadership, that we could only teach management, but that's not true. We can teach leadership. You just have to know where you want to go, because if you look behind you and nobody's there, then you're not leading. So it's always important to make sure you're aware of your environment. The key to successful leadership is their influence. It's not their authority component. It's not do this because I told you to do it. It's because it's the right thing to do. And the one thing I do want to mention, especially in our hospital systems, informal leaders are usually the very most influential people there are. They don't necessarily have to have a title, but you all know that emergency room nurse or that CCU nurse that carries a lot of power. She doesn't, or he doesn't necessarily have to have a title, but they're extremely powerful, and we need to work with those leaders. I'm not going to spend a lot of time on management styles and leadership styles because I want to talk about heart failure development, but I think it is important, especially after COVID, to understand transformational leaderships. Those that led us through the pandemic did it as we transformed care. Most physicians, most people in healthcare tend to be servant leaders. We are there to be servants to people that we lead. That's an important element because we tend to sacrifice a little bit too much when we become a servant leader. So you really want a blend of the different leadership styles. So what do most people think leadership is? Telling people what to do. I want you to do this, I want you to do that, I want you to round. That's not what leadership is. Leadership actually is a much more complex mechanism. It's making sure that, as we mentioned, that you're honest, that you're humble, that you praise your team, you thank them for working. People don't always leave jobs just because of pay. It's usually because of the work environment. So we want to make sure that we don't use our power inappropriately. We want to empathize with people. We tend to do that a fair amount in healthcare, and it really is really important. So our shared reality, because when we get to work every day, we are our work family, as I call them. We often spend more time in the hospital or in our clinics than we do with our actual families. So we have to make sure that our shared reality is understood. So this is a famous quote from somebody that I think you'll recognize, because the reality of leadership is that you have to be adaptive. Anybody hear of Campbell's Soup Company? And that's what he said, because Campbell's Soup was on the brink of becoming extinct, because things were happening so fast, things were changing so fast in the food industry, that he said, you know, if we don't adapt, we're going to lose. Now, who didn't adapt? Who didn't adapt were the big IBM computers. They never thought we'd be carrying around these phones that can teach us anything that we need to know. So they didn't survive. So we have to adapt to our situation, because in our healthcare worlds, there's two things that will never change. One is the environment is not in our control. If we learn nothing else during COVID, we learn that we cannot control the environment. But what we can control is how we react to our environment. Just think of yourself in the middle of a code, in the middle of the cath lab, in the middle of the emergency room, when things are very chaotic. You cannot necessarily change that environment, but you can change how you adapt to it. And our best leaders keep things calm during those crises. So you didn't think I was going to put Superman up there, right? So it is a superwoman. Those are your superpowers. So let's talk about emotional intelligence, because it is the most important thing when you leave here today that I'd like you to think about. I call emotional intelligence the mirror theory. So this is a very lovely banana. It sees itself as a very ripe banana, but its team of other bananas, when they look in the mirror, see a very rotten banana. What do I mean by that? Well, when I look in the mirror, I see Kathy Biga. I think I'm just a lovely person. I talk somewhat a little too fast. I love what I do. I have a passion for what I do. When my team looks in the mirror, they see somebody who talks too fast, that sends too many emails, and that's what you need to understand. As long as you can understand how other people see you, then you can be a good leader. It's really important to understand who you are. Dan Coleman is one that I like to use because I think he explains emotional intelligence the very best. So if you haven't read his book, it really is an excellent primer for leadership, because there's 5 main elements that we need for emotional intelligence. One is social skills. It doesn't matter if I'm an introvert or an extrovert, as long as I know who I am and I can adapt to my environment. We have to be self-aware. We have to understand where we come from. I'm not so good at this next one, that self-regulation. That's that work-life balance. That means that you need to make sure you take care of yourself, because we cannot continue to take care of our patients. And when we talk about designing our heart failure clinics, it's really important to be able to self-regulate yourself. And empathy, really understanding both our patients and their environment as well as our own environment, because becomes really important. And motivation. If we're not motivated, if we don't have a passion for what we want to do, we will never get where we want to go. So how do you develop self-awareness? It's really a crucial first step. The best thing to do is to ask your best friend or your spouse or partner and make sure they're honest with you, because that is how you build a foundation, is by asking people to be honest with you. Not just how we show up, but how we actually create that team environment becomes so very important. So for physicians, don't try to be someone else. Your secret sauce is who you are. Understand who you are as a leader. And be inclusive, be diverse. Our world is changing so fast, and as we design our heart failure teams, it is so important to be inclusive of everyone, even if it's the person answering the phone or if it's the nurse that's carrying out your treatment plan. We need to be inclusive. And allow your team to fail. It is okay to fail. We learn so much more when we fail. We need to make sure as leaders that we allow that failure and that we don't have personal agendas when we're trying to lead our teams. So last thing on leadership before we talk about how to do our heart failure clinics is the 70-20-10 rule, because I often get asked. I was just talking to a couple of younger physicians this morning who were going after their PhDs and doing all kinds of university level learning, which is good, but that's not how you learn leadership. You learn leadership in the day-to-day environment. You learn it by watching your mentors. You learn it by watching others. 20% will come from relationships. It'll come from people that you respect, that will work with you and help you. And 10% comes from the college, from the books. So courses such as these, congresses such as these are really, really important as we do leadership. I'm just going to do 2 slides on dyad leadership because it's something globally that's not well known. What do I mean by dyad leadership? Well, as many of you may know, I'm the first non-physician president of the American College of Cardiology. And what's critical to me, and Chris Kramer, who you heard from first today, is what I would consider my dyad. So Chris and I have been leading the college through these years of our presidential terms, which is very important. Same thing happens in your hospitals. You need that administrative person to help you make sure that your programs are successful, making sure that there's that collaboration with each other. So I do like dyad leadership. My dyad partner in my day job we've been together for about 25 years, and we can finish each other's sentences. But it's a very powerful team when you team up with your administrators. Make sure that you share each other's strengths. Make sure you hire people smarter than you are. Okay, so I think that's about enough on leadership, because it's not all about organizational charts. It's really all about how we can influence each other. So let's talk about heart failure. We just heard how important and how pervasive heart failure is in China. Access to care is critical. We talked this morning in a session how important it was to make sure that every individual in China wakes up every single day believing that they have access to good cardiovascular care. So access to care is so important. Whether we're in an urban area or a rural area, it does not matter. We must make sure that we have access to care. We also need to make sure we have equitable access. I love to take this picture with me because I think it really describes not only our heart failure patients, but any kind of cardiovascular disease state. So what is it really saying? You'll notice that the 3 kids all have very lovely stools. They're all the exact same size, so they're all being treated equally, right? But the little kids still can't see a darn thing. So somebody says, okay, let's do it equitably. Let's take the big stool away from the tall kid and put the little kid, give them 2 stools so they can stand on it, and then look, he can finally see over the fence. But what's the real issue? The real issue is the boards that are blocking everybody's view. Those are the barriers that we always have in healthcare. We need to take those barriers down. If we're not going to transform cardiovascular care now, it's imperative that we do it now. We must take these barriers down in order for our patients not only to live longer, but to live healthier. We also learned through the pandemic that the social determinants of health are critically important. I love working with my physicians. I think we do a phenomenal job as a CV team. But the reality is only 20% of our clinical expertise influences a patient's outcome. 20%. The other 80% comes from who they are. So when we talk about individualized treatment plans, when we talk about heart failure and making sure that we use the 4 pillars of medication, we cannot do that unless our patients can afford it, they understand it, they're compliant with it. So where they live, what their education is, what their finances are, that's where 80% of our outcome will come from. We must use our teams to understand that, to make sure that we can give our patients that treatment plan that works for them. Because right now, it's like an iceberg. What we see both in China and in the U.S. are these patients that are sick right now. They're on top of the iceberg. But much like the Titanic, look at all those patients that are just waiting because we're not doing a very good job with preventative health care. We're not doing a good job with hypertension. These are all our precursors. We must start to take care of these patients. And in heart failure, it's really critical. Also, who our team is important. It's very important to make sure that our team understand. I used to say our team needs to look like our patients, but that's not always possible. What is possible is that our team understands our patients' culture, where they come from, how their environment is. That's what's important. We also need to provide care where our patients are. We need to make sure we're out in the environment where they are, because oftentimes they can't get to us. So how do we do that in our heart failure clinics? Well, number one, ACC has designed this transformation of care that keeps our patient in the middle. It highlights all those things you're learning about at the Congress, artificial intelligence, all of our community resources, but we must keep the patient at the very center. So our coordinated care delivery requires a team. We can't do it alone. Our physicians cannot do it alone. So much like in the United States, when I met your nurses when I was out in the hospital yesterday, they have our nurses, they have our specialty trained nurses in the heart failure clinics, specially trained nurses in the structural heart clinic. Really important when we're setting up our clinics that we have those available to us. Also our pharmacists, our dietitians, also important. It takes a team to take care of our patients. You diagnose, the team needs to help with those guideline-directed medical therapies together. So this is Sam. Meet Sam. Sam comes with me everywhere when I travel globally. Sam was just diagnosed with heart failure. In the United States, he can enter our system any way of 6 different ways. When we first designed our heart failure clinics, Sam was treated differently depending on where he came into the system. If he came in and somehow made an appointment with an interventional cardiologist, he just transferred him over to a non-invasive cardiologist. Came in through the emergency room, something else would happen, primary care. So Sam looked like this when we finished with him. He was extraordinarily confused. He had no idea what he was doing, where he was going, or how his care was supposed to unfold. So what we did was we pulled all the chaos away from Sam and designed a heart failure clinic, what we call across the continuum, so that whether he's at home or whether he's at end of life, his treatment plan is the same throughout our entire system. It was very, very important. We also make sure our heart failure patients are seen within 48 hours of discharge. That keeps our readmission rate. We just heard about the readmission rate in China, not only how much money it costs, but how disruptive it is for the patients. So when we want to build a heart failure program, this is just a good graphic of how you start from the bottom up, always keeping that patient in the very center of what we do, making sure that we use registries and data in order to guide our care as we're taking care of our patients, making sure that the team recognizes that individual plan of care that is different for every single patient. So very critical. So in our last couple minutes together, just designing our clinic, making sure that we have a champion that works with us, a business plan. We've talked a lot about advocacy, whether we're in China or the U.S. We have to make sure that we have a financially sustainable way of doing our clinics. And this is just a good description of each member of the team and what they actually do to make sure that everybody sort of stays, what we say, work at the top of their license, to make sure that they're taking care of the patients as well as we can, making sure that I don't have physicians rooming patients, that I use our medical assistants to do that, our secretaries to do our orders, those types of things. And this follows our plan of care. You can see we see the patient very, very frequently for the first 3 months. That's to make sure that their medication reconciliation, their diet, their lifestyle, that we touch base with them very often to make sure that we're on the same page, making sure that they get the care that they need. When we started this, our readmission rate went from 23% down to 12%. And we've been able to hold right around 12 and 13% for the last 3 years as we put those into our patients' lives. So how do we optimize a heart failure clinic? Well, number one, you're going to lead it. You just learned all about leadership, so you're going to lead it. We're going to make sure that that heart failure clinic is personalized, that we do personalized plans of care for our patients, making sure that we have the right staff. We're all in a workforce crisis. It's very difficult to get people, so we need to make sure everybody works at the top of their license. And then we need to track our progress, make sure that we have quality outcomes, quality indicators, so we know that our patients are not being readmitted, that we're doing diuresis appropriately. So I'll just leave you with a few quotes here for leadership, because I think we start with leadership in order to have good heart failure clinics. I know China continues to do a wonderful job, but this is an epidemic. We need to make sure that we are treating our patients aggressively and consistently. And so with that, I thank you so very much, and I hope you have a great rest of your Congress.